Okay, thanks so much, Wendy. I thought I was the controversial one, so this is now pretty easy. Tim's a hard act to follow. He's one of my favorite Twitter partners, so I get a lot of entertainment from Tim, and we all got a lot today, so that was good. And the reason that I'm happy to continue to be asked to be in this room and to talk to people is because I have been a little bit skeptical in the past of the steamrolling new antiretroviral therapy and tried to continue to struggle with putting this into a public health framework. And certainly my job now at the BC CDC, where I'm confronted with public health issues all the time, it's just driven that home more and more. And so I've added public health and hepatitis C surveillance, because hepatitis C surveillance is terribly boring compared to what Tim gets to talk about. I get up every morning and look at odds ratios, and he gets to look at Vogue magazine. So it's not really fair. But anyway, so I'll try to come across get across the surveillance. I owe all of this talk pretty much to Naveed, who's sitting here, because when I was asked to do something on surveillance, Naveed has all the surveillance slides from BC, so he sent me about 9,000 slides, and then I kind of went through them and picked a few ones that I understood. So I'll get started. So the one thing I just, maybe it's a text slide is kind of inappropriate, but I just wanted to just define public health for people, just to get us in the right mindset. So public health refers to all organized measures to prevent disease, promote health, and prolong life among the population as a whole. Its activities aim to provide conditions in which people can be healthy and focus on entire populations, not on individual patients or diseases. Thus, public health is concerned with the total system and not only the eradication of a particular disease. And that brings us to where we fit in. So with the introduction and increasing availability of highly effective antiviral therapy for hepatitis C, how does public health stay relevant? So if we turn this into a clinical disease, like any clinical disease, where you get a diagnosis and you go to your doctor and he gives you effective therapy and then you're cured, how does public health stay relevant in that kind of clinical environment? And my role, I think, as a physician and in my position is to try to make people's lives as healthy as possible. And if hepatitis C treatment's at the top of that list, then that's what they should do. But if housing's at the top of that list, that's where we should focus too. So it's not our goal. When I listen to Morris talk about elimination, I sometimes wonder if that's a goal. If that is really our goal, to eliminate hepatitis C, shouldn't our goal to be eliminate stigma? Shouldn't it be to eliminate homelessness? Shouldn't it be to eliminate addiction? I mean, whatever other things we want to eliminate, it might be just too convenient to say, well, let's just go after this virus. I think surveillance, though, is extremely important and gives us a lot of the answers, and we're really happy in BC to have a really good database, and I'll explain that to you in a little bit and go over some more mundane slides of epidemiology. But I think the main things that we want to look at when we're looking at hepatitis is to understand the epidemiology. So we need to know about the transmission, risk factors, outcomes, how we are doing in terms of providing care, so the cascade of prevention and care, programs, inputs, and interventions that we're trying to influence hepatitis C with. What is the actual impact of the program? So we need to have databases that help us to really visualize that. And is the program equitable? Are we meeting equity needs? And again, I think that's a very important concept throughout all public health, is it's really health equity. And almost everything that we deal with in the disease world has equity has a huge influence on that, and poor, marginalized people do worse in everything. This is just a standard graph of what's really happened with hepatitis C in our country, and so we see this huge spike in the late 1990s and 2000s, due mainly to just increased intensification of testing. So we have a lot of prevalent hepatitis C cases that we've uncovered. And as we've been more successful in targeting testing for risk groups, we've detected more and more. And over time, that's sort of leveling out. The top bar is BC. I think it looks so much worse somewhat because we have better data to support it, but the trends are similar across Canada. And then we also have the ability to look at people who had actually seroconverted. So those who weren't prevalent infections, but the blue line represents people in the database who had a test negative and then had a test positive. And as expected, that shifts the curve a little bit over to the side, but the new infections now are becoming less and less. And I know in my clinical work and the clinical practices, the days when multiple people would test positive for hepatitis C are over, and most people that in the clinical setting among at least risk groups, that known risk groups, it's less and less to find that they had a negative test last week and now they're positive. Now, this is where a lot of the data that I'll present comes from, and I'm not sure of the history of this, but apparently during Woodstock, Mel Krashen was using LSD and then came up with this concept of how we create this massive database. And so it's really been the life work of Mel Krashen and people at BCCDC. Since we have a centralized opportunity to do all the HCV testing on site, we have that captured. The trick was to develop these linkage with large administrative databases. And over time, we've been highly successful in doing that. And it's really just been the past year or two that Naveed and his group have really started to work with this data, and there's a whole range of really high impact publications that have come out of this simply because we were able to create this excellent data set. So there's many things we can look at now, and I'll just highlight some of them as we go along. The other beauty of this is we do have permission to get regular updates. So some of the data that I'll show now is now a couple years old, but the last download is we have it, and so people are frantically looking at this. And I don't know why Naveed's wasting his time moderating this when he should be in his computer trying to analyze some of this data. This is where it looks right now. There's over 1 million people, 1.1 million in the testers cohort. We have about 1 million that are HCV negative, and we can compare them to about 67,000 known HIV positives in the province. As expected, the major outcomes of death, decompensated liver disease, and hepatocellular carcinoma fall heavily onto the positive side, but we can compare them with the negative side. One of the things that had been talked about, and Morris talked about it in his talk, is the kind of twin epidemics that we have. And there's the people, in this case we split it, people born after 1965 and people born before 1965. And you can see that as far as the other factors that are driving some of this transmission, drug use, mental illness, and co-infection, they're very much more prevalent on the younger group, those born after 1965, as totally expected. This is a cascade of care. Again, we'll be able to update this soon, and again, it reflects more the interferon era as far as treatment and cured, but you can see we have a long way to go. So we have these treatments now available, and we're really in the scale-up phase in British Columbia, but you can see that starting with an estimated 73,000 people that are prevalently infected, there's about 54,000 that have been diagnosed with an antibody. It drops down again for those who've had an RNA test, then how many been genotyped, how many treatment initiated, and how many were successful with their treatment. So we have a long way to go in trying to scale up treatment and get those cures much higher. This is looking at factors associated with those receiving care, and again, as quite expected, those with HIV co-infection were less likely to be treated. Those with cirrhosis were less likely to be treated. Those with a history of mental illness were less likely to be treated. So there was quite a discrepancy as far as those who actually were initiated on treatment. There's been some cool work done as far as algorithms to look at material and social deprivation. Again, more in the kind of syndemics look of this epidemic. And you can see moving across the slide that the more privileged people are, the more likely you are to this is HCV positivity. So in our whole cohort, the more disadvantaged you are, the more likely you are to be hepatitis C positive based on both the material and the social deprivation index. This looks at rates of hepatocellular carcinoma. Again, really excellent data, not really because the database is so large. We can really make some very interesting analysis. And so we can see that over the decades, the number of carcinoma rate, the hepatocellular carcinoma rate is quite high and going up. This looks at cirrhosis rates, and again, quite remarkable from 1990 looking to 2012 over a couple of decades that the population rates in the graph looks at rates per 100,000 population are going up, and we actually have absolute numbers of cases of these stratified by gender. One of the I guess hallmarks of what happened, and many of us who were in the HIV world and now in the hepatitis C world, the switchover in BC came as far as mortality in about 2007 when the liver-related deaths now started to surpass HIV-related deaths, and those trends have continued with a really brisk uptick in the hepatitis C-related deaths. This is all-cause mortality. Again, over time, there was quite a abrupt increase in the late 1990s and 2000s, and that's leveling off a bit. And then graphs looking at liver-related mortality. And again, some of this is now published, and I won't take a lot of detail, but just very rich data looking at how we're heading and what we can expect with liver-related adverse health outcomes. This looks at the incidence of hepatocellular carcinoma by clearance state, and the red bar is people who have failed treatment. So these are obviously people that were more difficult to get through their treatment or were not successful in their treatment, and their risk of hepatocellular carcinoma is far greater than those who spontaneously cleared, for instance. And then we have the ability with the linkages to look at different factors, other interventions that can be associated with successful initiation treatment and successful treatment. And so we can show from this paper that really highlighted that people on opioid substitution therapy did better. So again, trying to measure the impacts we're having with our other supportive work, especially in the drug-using community, well, only in the drug-using community, and how we can measure the impacts of those different interventions. One of the things that we wrestle with is what people are actually dying of and all these competitive risks out there. In the next few slides, I'll just show you that many people that we follow don't live long enough to die of their liver disease, and there's so many competing risks. So these three categories are people that are HCV negative in the cohort, people that have seroconverted, and those who are prevalent infections. And all-cause mortality actually is higher in the seroconverters. So these are younger people, but they have so many competing risks for their death. And then the longer term, like the hepatocellular carcinoma, is expected would be in people that were prevalent infection and probably were infected very much longer. And now we're dealing with people that have maybe been carrying hepatitis C for 30 or 40 years, and they're becoming identified as having hepatocellular carcinoma. So a very interesting way to kind of look at that. The other way that it's been shown is looking at the cause of death by other competing causes of death. So non-liver cancers, cardiovascular disease. So these are the percentage of deaths amongst people who have died in the cohort. And so we can see that overall there's a range of competing reasons why people are dying. Again, if we break this into the two cohorts, so there's marked differences in what people are dying of in the older birth cohort versus the newer cohort. And so this is cardiovascular diseases are higher, And non-liver cancers are quite high in an older age group, respiratory diseases, diabetes, and such. And if you look at the same kind of analysis in those with more recent birth cohorts, the drug-related deaths really pop up very high as a competing risk factor, as does HIV. So we have to keep in mind, in a public health way, that there's other competing risks of death. Which brings me to, I just wanted to touch a little bit on overdose because I'm hoping it illustrative of the point that I was trying to make. And this is where I spend most of my time now looking at the overdose crisis in British Columbia, and there's many other parts of Canada this is also happening. And again, I think BC looks worse because we have better data collection right now, but it's really a huge problem and devastating the very community that we've been focusing on so long. And you can see this massive uptick in the past 2 years, and we had almost 1,000 people die in BC last year, and the monthly statistics aren't that much better. And just after almost a year into calling an emergency and coming up with all these solutions, November, December were the worst months ever. And so it dropped down a little bit in January, but we're not really winning with what we're doing. But again, there's all these people that were probably in line to get hepatitis C treatment, but they just didn't last long enough. And many of the same factors that are driving the overdose crisis are the same factors driving hepatitis C infection and death. I put up these 12 points. We've had a lot of meetings about how to handle the overdose, and it just occurred to me when I go down this list that basically they're almost all the same things that we've advocated for getting people both preventing their hepatitis C, getting them in care, and getting them through care. So all these things have major overlaps, maybe not in the loxone therapy, but and it also when we had a similar disaster in the 90s in Vancouver with the HIV epidemic. Again, all these things we were supposed to do, and all we ended up doing a really good job at was diagnosing and treating people's HIV. So people aren't dying of HIV anymore. But all these other more social drivers of the problem we have not really got a grip on yet. And many of these things that we're looking at the overdose, I could actually present them as things we should be doing for hepatitis C. And we have to keep that in mind as far as our public health approach goes. Whoops. I went too far, but didn't matter. It was just a picture of people living in tents. But just again to illustrate that this is the, oops, I can go one more. So this is a street that I work on clinically. We have a long list of people that are lining up to get hepatitis C treatment. And I'm quite happy that they should get hepatitis C treatment. But when I walk into the clinic and that's what they're after, and if I ask them what is your 10 biggest problems today, their asymptomatic hepatitis wouldn't be one of them. So my role here is trying to generate some discussion that our whole approach to hepatitis C needs to go beyond testing and treating, and that we have to meet people where they are and prioritize what our interventions need to be. And not to say that getting rid of hepatitis C wouldn't be fantastic, but if we only focus on that, we'll be like we are with HIV. And it's successful, but not successful enough. So thank you very much.
Thank you, Mark. We have time for a few questions.
Hi, my name is Gisela McPhail. I work in this population in Calgary. I'm an infectious disease physician treating. One of the things that we notice is when you engage people who are injecting drugs in hepatitis C care, it gives you an opportunity in a multidisciplinary clinic to address the housing, address the addictions, and it's a way in to help people with all those other multiple social determinants of health. So don't be quite so quick, please, to dichotomize that.
Sure. Well, I totally anticipate that question, and I've had these a million times. So I think that is a great way to engage people in a multidisciplinary care. I think that is one of the major ways that we can influence the bigger picture if we do get people engaged. And hepatitis C treatment is a great way to do that. And so I think all our models in this population should be a multidisciplinary team care and to look at how we support people overall. So I do think there's excellent models across Canada where that's working. It's probably, we have to then scale those up quite quickly, because if we have our eyes on treating a lot of people quickly, we want primary care physicians involved, we want as many people treating as possible, and in many of those situations, they're not equipped to really do that. So I do support that, and there's been, you know, great examples. First time I worked with Jason Grebely, that was kind of his thing in the downtown east side, and having clinics like that. So that's fantastic, and so I'm not denigrating that approach at all, because people, I'm not saying people don't think about that, but if we actually have hundreds of thousands of people we want to get treated very quickly, it's unlikely we're going to be doing that for enough people.
Thank you very much. I'm Frank Bialystock, and I'm a lay member of CanHepC. When you had the actions list, I think the second last slide, can you just bring it back?
I'd like to be able to.
Okay, all right. What I don't believe that you had on there a recommendation that the Canadian government get really tough with China, because this is where all of this stuff is coming from. These opioids. We seem to be very, very, welcoming to Chinese business and all sorts of other things, how shady it is. And yet, when it comes to this, there doesn't seem to be any action. I'd like your comment on that, please.
Well, I think that's called the war on drugs. So I don't think that's workable. I think that, if we can do some things that, we don't want huge shipments coming in, but I do think that's a lost cause. I wish the government wouldn't spend any money on that, to be quite honest. I think that there's a need for drugs there. If fentanyl was stopped abruptly today, there'd be something else. So it's all about demand. And so we need to, treat people, get them into substitution care, treat their trauma, do all these things, because in my mind, it's 95% demand. And the supply is not really, we can't do much about that.
Thank you.
Hi, my name's Justin Chan. I'm an infectious disease doctor at Mass General Hospital in Boston. There's been some studies in Massachusetts and the US looking at physician prescription behavior over the last decade, and the rise in opiate prescription paralleling the increase in IV drug use amongst young population. I wonder what your perspective is with that factor in BC, and I don't see much of a mention of physician prescription behavior on your list here. So,
okay, it is. I think it is on the list. So better to prescribe, appropriate prescribing and dispensing by healthcare providers. So it's on the list. Sorry to the organizers, we're not supposed to be talking about overdose, I don't think. But so I think there's two problems. One is historical, and I do think physicians' prescription behaviors have contributed immensely to the situation we're in now. But now certainly in some communities is not the time to pull back. So we've got very aggressive. Our policies are about 5 to 10 years behind what they should have been. So these prescription restriction type policies should have been going on a decade ago. Now we have all these people, and the worst thing we can do is tell them, I'm no longer going to give you these drugs, because basically we're telling them to go find them other places. So that's, in my mind, been a huge contributor to what's happening with fentanyl. Why else would fentanyl be there if there was other drugs that people could get? So it's really, that discussion needs to be put in two very separate categories. If your patient has back pain, don't give them Dilaudid. If your patient's on high-dose Dilaudid, don't take them off right now unless you have a better alternative. Thank you.
Thank you. So one last question, thanks.
Thank you. My name is Yogesh. I work with the Public Health Agency of Canada.
Good to see you, Mark, after a long time, and thank you for the wonderful talk. My comment actually relates to both previous presenter Tim and Mark, and I think when we talk about public health interventions, we have erred on two main issues. The first, we have forgotten about health, and we have equated it to the jabs and pills. And second, we have totally forgotten about the public. It's a one-way communication. Of course, Katy Perry will always have more followers than any one of us. But coming back to your presentation, Mark, of lately we have seen that the public health programs that we are developing, and I have two good examples to give you, is one of the programs that we were developing for MCH care in India. We are giving $100 for every pregnant woman to cover her traveling cost as part of the program. We can either have collaborations or we can have the inbuilt finance or actions incorporated into the programs when the person is brought into the care. It's not only going to be test and treat, it's going to address all the social stigma, it has to address the housing, the other social determinants of health. And second program that I launched was in late stages of Ebola in Sierra Leone, when people were totally against quarantine. And we started giving them money. We started bringing in people to harvest their fields, and so quarantine was accepted. So we built in part of that money for hiring the people to harvest their fields as part of the program. So we'll have to see the programs, public health programs in times to come in a broader perspective, addressing all the social determinants of health, whether it is through collaborative approach or through inbuilt approach. Thank you.
Great, thanks for that comment. If I could just, I know you want to get rid of me, but the one thing I think we can do a better job at, it's so easy if you have a multidisciplinary program to measure how you do with your hepatitis C, but we don't put any effort into measuring how well we're doing with all our social support. So I think that, and that would require resources and money and really thinking through that. So if you have a package for somebody that includes housing support and substitution therapy and trauma counseling and all those things, they should be on your list of measurables just as much as whether they got an SVR. And I think that we have the best of intentions when people come in, but at the end of the day, we're often left with SVR, and none of that other stuff's really been taken care of because it's very difficult and it takes a lot of resources. So one thing I'm just thinking off the top of my head, when we're coming up with, when we're evaluating somebody, and if we really want a multidisciplinary approach, we should come up with some really good ways to measure that, follow that, if there's gaps, that we have resources to put in to strengthen that. So, we should really take that seriously and really have hard outcomes that we're looking for. So.